such as polyethylene, play a central role in our everyday lives. Normally, when polymers are heated or put under stress, their form will change. However, in many cases, you want these products to keep their original form, even if they're exposed to the most challenging conditions. This is where Nourion's organic peroxides come into play by a process called cross-linking. Let's take a closer look at how this works by using polyethylene as an example. Polyethylene consists of long polymer chains which can slide past each other. When this happens, the shape of the final product changes. By cross-linking the polymer, this can be prevented and the products will keep their original shape. To cross-link the polymer, organic peroxide is added to the polymer. When heated, the peroxide falls in two parts called free radicals. The radical abstracts a hydrogen atom from a polymer chain, forming a new radical on the polymer itself. When it finds a radical on another polymer chain, they recombine and form a strong crosslink. This process continues throughout the polymer, building a strong polymer network. This network prevents the polymer chains to slide over each other, providing an excellent form stability. So thanks to Nourion's organic.
Okay. So I think this video kind of clarify or give you the concept of how these cross-linking has been used in manufacturing. It's the same concept when we talk about the cross-linking, the ophthalmic use for corneal ectasia. I think the idea now is kind of clear after we watch this video. So why do we use the riboflavin? Why the riboflavin than any other type of supplement? Riboflavin or vitamin B2 is actually, we consume this vitamin on a daily basis from our diet. Talking about specific type of meats, vegetables, fruits. But choosing riboflavin because it has advantages or has something unique behind it. The first point here that why we choose riboflavin or vitamin B2, it's the enhanced absorption. So usually the oxygen molecules in the cornea cannot be directly activated by light. So the riboflavin, when it's combined with the UVA light, it's actually causing a reactive form and the oxidation needed in the corneal stroma. So that's the first point or advantage. The second point here, it does not allow it to act as a tissue protector. It does not allow the harmful transmission of UV light to go beyond the treatment, because we want the UV light and the riboflavin to be in the anterior stroma and do not go to the posterior stroma and the endothelium. So it's very important for us to keep the endothelium, retina, and the lens and the posterior structure very safe and intact from the high energy UV lights. So that's why we choose the riboflavin. Let's talk now, let's talk clinically. What are the indications for the use for corneal cross-linking? We're talking about based on the US FDA. The US FDA approved in 2016 the corneal or corneal cross-linking for two indications: post-surgical corneal ectasia. This one is specifically for patients who had a refractive surgery like LASIK or PRK, and after the surgery, they developed corneal ectasia. And the second indication is a progressive keratoconus. The patient has a keratoconus and it's progressing. Also, they had an age limit of 14 and older, and minimum corneal thickness of 400. So anyone is below 400, they're not eligible for the procedure for corneal cross-linking. But there is a way to overcome if the patient is let's say slightly below 400 microns. There is a way when we talk about the steps of the procedure. Other uses, they're not approved by FDA for cross-linking, but clinical studies shown they are effective. So we're talking about pellucid marginal degeneration. It's another form of corneal ectasia. Corneal melt, infectious keratitis has been shown in many studies that corneal cross-linking can benefit patients who have infectious keratitis, especially the one who have a severe infectious keratitis and antibiotics do not work very well with those patients. So we can try the corneal cross-linking. And also corneal edema. So who are the best candidates? So now let's say you have a patient. How do you know this patient is going to benefit the most from the surgery? I think this is very important for us because we need to target those patients in your clinic to have them benefit the most from the corneal cross-linking. So these points, just have them in mind. First, target the patient with a mild to moderate corneal or keratoconus. We need to have patients who are still at the beginning of the keratoconus progression. And also you have to have the documented progression. What do we mean by documented progression? We know the keratoconus usually progress. If you see that the patient today, you have the thickness and the curvature at a certain amount. And then after, let's say 6 months, there is a steepening and also there is a corneal thinning. But in some cases, there is no progression. If there is no progression, there is no indication to do the surgery or refer them for the surgery. You just keep monitoring the patient. But for this surgery, you need to have a document or documented progression. Either you follow up with the patient after a few months and you see how, okay, then there is a progression, or you have a reported information from another optometrist or ophthalmologist for this patient. We talked about the corneal thickness. It has to be 400 or greater microns. We're talking about central corneal thickness. Minimal or no corneal scarring. Patients who have no corneal scarring or minimal corneal scarring benefit the most from the surgery. So if the patient has like a significant amount of corneal scarring with the keratoconus, usually they have a worse outcome than the one without corneal scarring. Usually target the patient with the better visual acuity. So best corrected visual acuity, 20/40 and better. Also younger patients. The younger patients, the better the outcome. For example, if I have a patient who's 20-year-old versus a patient who is a 35-year-old, it's going to be better for the patients who are 20 years old. So those are the best candidates. That doesn't mean if someone who is slightly above 20/40 cannot do the surgery. No, we still can do the surgery. But those are the best candidates. We keep recommend those patients to have a surgery because they benefit the most. On the other hand, now we're talking about patients who have a higher risk or higher risk patients, what we call them. So if the patient has any of these, then maybe you can not tell them about the procedure, or maybe they're not fit for this procedure, or maybe you can refer them to the cornea specialist and then they will do this decision. So the patients with thin corneas, pregnant women, because in a pregnant woman, one study found after the surgery, there is progression. The keratoconus is still progressing after the surgery. And that's for many reasons. And one of them is hormonal changes that happens during pregnancy. Severe disease, severe corneal opacity, patients with prior herpes infection. We know herpes infection or keratitis. Patients who had herpes or herpes simplex infection, usually with the exposure to UV lights, they can have a recurrent or they can have the infection activated again. So that will be contraindicated in those patients. Connective tissue disorders, autoimmune disease, any condition or any disease that can affect the wound healing. For example, when we talk about wound healing, one of the great examples of the conditions, common conditions that affect the wound healing, we're talking about diabetes. So if the patient is diabetic and their diabetic is not under control, usually what we recommend for them, or just keep in mind, they might have a poor wound healing. Why we need the proper wound healing? Because we remove the epithelium in the surgery, we need the epithelium to grow back within a few days. So if the patient is diabetic and do not have a proper wound healing, that might take them longer, and the complication will be worse with those patients. So keep those in your head when you talk to your patients about the corneal cross-linking. So now we're talking about the actual procedure. How is it done? Before we're talking about riboflavin, and riboflavin comes in solution. This is one of the systems they used. There is something from the company called Botrixa. We have two solutions. They both have riboflavin in them, something called Botrixa viscous, and the other one just Botrixa. So Botrixa viscous used during the riboflavin loading and during UV exposure. We're going to explain that in a little bit. The Botrixa is a hypotonic riboflavin. It's used to induce corneal swelling. So we talked about if the patient needs to have a 400 microns of corneal thickness. So if, let's say if the patient does not have a 400 microns, he has a 380. He's very close to 400, but it's not 400. We give them a hypotonic riboflavin to increase the fluid inside the cornea to make the cornea thicker and reach to 400, and then we can do the surgery. So that's the use for the hypotonic riboflavin, the Botrixa. So now to the actual procedure. So there are straightforward, easy 4 steps to remember. The first one, what we do, we remove the epithelium of the cornea. So the epithelium is usually the first layer of the cornea. We remove the entire epithelium within a central 9 diameter circle. After that, we give the patient Botrixa viscous, the regular one. 1 drop in each eye every 2 minutes for 30 minutes. The third step, we check the saturation. We give that amount of riboflavin because we want the riboflavin to be a lot or saturated in the anterior stroma. So we check for that, and then we verify the corneal thickness is 400 and greater. And if it's less than that, now we use the hypotonic Botrixa. If the patient is a 400, we don't use it. If the patient is less than 400, we give the patient the hypotonic every 5 to 10 seconds until the cornea reach 400. If the cornea, when the cornea is 400 microns, now we move to the last step, expose them to UVA for 30 minutes. And the total energy is about 5.4 from the UVA. And also during the UVA exposure, we still give the patient the Botrixa viscous, the regular one, every 2 minutes. So the procedure is long. And the reason I'm talking about this procedure in details is the patient might have the wrong idea about corneal cross-linking. We know with the LASIK and PRK, the process or the procedure is very fast. You're talking about the entire thing is done within 5 to 10 minutes. But here it may take an hour or longer for procedure. So the patient needs to know the procedure is longer than the other type of refractive surgeries. Now we're going to talk after the surgery, what's going to happen. Right after the surgery, the excess amount of riboflavin can be rinsed off with saline. Usually we give the patient a bandage contact lens for the next few days, 3 to 5 days, until the epithelium heals. Also, we give the patients medication or topical medications. They're very important for a few weeks. Antibiotic to control or to prevent any infection, because the epithelium will be removed and the eye or the cornea will be at risk of infections. So we give the patient antibiotic for a week, steroids to control any inflammation that might happen for about 2 to 4 weeks. We start heavy doses every hour, and then we taper it until the end of the period. And then we give lubricants to kind of have lower the symptoms of dry eye that may happen. Typical follow-up, how we follow up with the patient after the surgery. The next day, we see the patient, 3 to 5 days after the surgery, and then 1 month, 3 months, 6 months, and 1 year. What patient should expect after the surgery in terms of complications. Are they going to see 20/20 after the surgery? Are they going to have no pain, or is there going to be pain? All these need to be discussed with the patients and have to be made, then they need to be made very clear to the patient. So there is a foreign body sensation right after the surgery when the anesthesia effect wears off, and there is pain. Also, patients can report hazy vision. So their vision will be dropped, and we're going to explain that. That can last for a few months. And that's because of the epithelial removal, because you remove the epithelium and it takes time to grow. Also, you tell the patient the vision can fluctuate in the first few months after the surgery. Also, the cornea the changes in the corneal curvature can still, you can still see it up to 6 months after the surgery. Since we remove the epithelium with the surgery, it's very important to know how long does it take for the epithelium to grow back. So the epithelium takes about 4 days for completion, to close the wound. We know the epithelium has several layers. It's not just one cell layer. It has about 5 to 7 layers. So to close the wound, it's very fast. It's within 3 to 5 days, about 4 days. But to have the entire epithelium grow as it was before the surgery, the entire 7 layers, that will take up to 3 months. So that's why you see the vision fluctuation that happens in vision haze, because it requires for the epithelium, corneal epithelium, to grow that long. The outcome is very important to discuss the patient. The first question the patient will ask you, how successful is this surgery? Is it 50%? Is it 70%? So from the studies, it's a very high percentage. The success rate is 93 to 95% when we use epi-off. So epi-off, it's when we remove the epithelium in the procedure. There is another procedure we're going to talk about. It's called epi-on, when you keep the epithelium on. So this success rate only for epi-off. And also the study showed the K reading, because with keratoconus, what you see is actually the cornea getting steeper with time, and there is a thinning. So our goal is to stop the cornea from progressing. So the cornea will be like either stable. But in some studies showed that with epi-off, there is a flattening in the cornea by 1.5 to 2 diopter, which is great because we not only stopped, we actually flattened the cornea, which can improve the vision slightly. Other complications, we talked about minor pain, corneal haze, corneal edema can happen, microbial keratitis, loss of vision or best-corrected visual acuity, and treatment failure. Corneal haze is kind of expected, and the corneal haze because first, it's going to be more in the anterior to mid-stroma. Corneal haze is due to the fluids in the cornea, because with the surgery, what we're doing is removing the epithelium first, and then we add the riboflavin. So the riboflavin is a fluid or a solution. So those fluids will be in the corneal or anterior corneal stroma, will induce a corneal haze. So it's expected to have a corneal haze in the first few months of the surgery. Some patients, they have it up to a year, but it will be improving after the surgery. But if we're talking about the corneal haze with the PRK, it's a refractive surgery, will be concerning. That's kind of, it's a little bit of an issue if you see a corneal haze with the PRK, but with the corneal haze with corneal cross-linking, it's kind of expected, and it should not last longer than 1 year. Corneal edema, it's one of the complications that might happen. Corneal edema happens when there is fluid in the cornea, in an irregular amount of fluid. And due to the dysfunction of the endothelial cells. So we talked about the epithelium, which is the top or the top layer of the cornea. The endothelium is the bottom or the back surface of the cornea. So if you want to know something about endothelial or the corneal endothelium, there are two things very important to know about the corneal endothelium. First, corneal endothelial cells have a very important function, which we call it the pump mechanism. They control the amount of fluids that gets into the retina, into the cornea and out of the cornea at a regular amount. Because the amount of fluids that get into the cornea, they are very important to keep them at a specific amount to keep the corneal tissue transparent. That's the first point. The second point about the corneal endothelium that you need to know, when you lose or there is a corneal endothelial cell damage, there is no regeneration. The corneal epithelium, on the other hand, it regenerates. But the corneal endothelium, when you damage it, it's gone. You just live with the number of cells that you have left. So it's very important in this procedure to keep the corneal endothelium very safe from the UV radiation or the UV light. That's why we have the rule or the rule for 400 microns, because the patient to have a thinner cornea, they have a higher risk of that UV light to reach the endothelium and damage the endothelium and have a more problem or issue with the surgery than they can benefit from it. That's why we have a 400 criteria. Microbial keratitis has also been reported, but it's a smaller percentage, about 1% of patients. It's more sterile than infectious. If it lasts longer and wasn't treated, it can result in corneal scarring. Loss of best corrected visual acuity. Here is a very important point to mention. What is the main goal of this procedure? Corneal cross-linking. What's our main goal? Our main goal is to stop the progression of the keratoconus, the disease. So if the patient comes to you and they expect to see 20/20 after the surgery, that's not going to happen. It's very unlikely. And the reason why, you have to make everything clear to the patient. The purpose or the main purpose of this procedure is to stop the progression, not to correct your vision. That's a very, very important point to tell your patient. That's why the majority of patients, and they had the surgery, their vision stayed the same. This is great. Or there is a slightly improvement because we have the corneal flattening happens. But you do not expect, if the patient before the surgery, the uncorrected visual acuity is a 20/80, to see 20/20. They might see 20/60 after the surgery. There are a small percentage of patients, they have reduced visual acuity over 2 lines. The percentage of treatment failure, when we talk about treatment failure, we don't mean the patient cannot see well after the surgery. The failure of the treatment, it's when the patient is still progressing after the surgery. The keratoconus is still progressing after the surgery. So it's about 2 to 8% of patients still progressing. And that's about the complication. What's the difference, now to another point, what is the difference between the epi-on and epi-off? Epi-on, it's very clear. You do the cross-linking and you leave the epithelium on. You don't remove the epithelium. Epi-off, you remove the epithelium. That's it. That's the difference between the two. Let's talk about the epithelium. How is that going to make a difference in the surgery? The epithelial cells, you can see here is the epithelium. You can see many cells, many layers of cells. We have the superficial cells, and now in here we have the basal cells. So between one cell to another, there is something called tight junctions. Those tight junctions are very, very important because they keep the fluids from getting, or the tears or the tear film getting inside the corneal tissue. Also, they reduce they have antioxidants, reduce the oxidation in the cornea. But with the treatment, this is not going to benefit us. The epithelium also, we had two components with the surgery, with the corneal cross-linking. The first one is the riboflavin. Our goal is to get the riboflavin to get to the anterior stroma. The second goal is to get the UV to the anterior stroma. Having the epithelium on without removing it actually will limit the amount of riboflavin with the tight junctions, and also decrease the UV penetration and decrease the oxidation. So that's the difference between the epi-on and epi-off in terms how they're going to affect the efficacy of the surgery. Is it going to be beneficial or not? So if we compare the two, we keep the epithelium on, we don't remove it. The efficacy and how effective the surgery is going to be lower. But the complications will be less. This is good, but this is not good. With the epi-off, when we remove the epithelium, we get higher efficacy. That's what we want, but more complications. We don't want more complications. So the question here, which corneal cross-linking procedure would you recommend to your patients? If anyone wants to participate, you can raise your hand or open your mic and feel free to answer. And if you answer, please provide us with your explanation why you picked the epi-on or epi-off.
We have many people actually, they are raising their hand, but I'm not sure if they are for these questions or.
Okay.
Yeah.
Or you can write in the chat if you want to answer the question. Honestly, I wanted to do a poll question to see the answers, but I was not able to do that. So the correct answer here is the epi-off. We still have the higher efficacy. That's why the FDA or the US FDA approved the epi-off, because it's higher efficacy. We want the higher efficacy. The complications, okay, we still have more complications than this procedure, but the complications in this case, we can control them. If we pick the right patients, if we give them the anesthesia, if we give them the medication right after the surgery, if we do the correct or the typical follow-up, we follow up with the patient on time, that will help us in reduce the complications. So the epi-off will be the right choice because it has higher efficacy. So how effective the epi-on is? It doesn't have any efficacy at all. Does it slow the progression or not? So here's the study was done on epi-on. So it has over 500 eyes with keratoconus or post-laser ectasia. So the surgery is very similar, but they don't remove the epithelium. The outcome here, the flattening happens on the corneal curvature is about 0.5 diopter. It's a half a diopter. And there is an improvement with the best corrected visual acuity with one line. So it's still effective, but when you compare it with epi-off, it's a lot less effective. Now let's talk about something else, which is the other uses. We're talking about the corneal cross-linking for infectious keratitis. The corneal cross-linking can reduce inflammation and inactivate the infectious organisms. If you're talking about bacteria, can damage the DNA and RNA of bacteria, and that treat the infectious keratitis. We have the ROS, or the reactive oxidative species, are actually thought to have an antimicrobial effect, may reduce the risk of corneal melt and the need for corneal transplant in the future. When we talk about different infectious keratitis, it's more effective against bacterial versus fungal and acanthamoeba. So this procedure, if we want to look at the corneal cross-linking for infectious keratitis, it's called PAC-CXL, photoactivated chromophore for keratitis corneal collagen cross-linking. What usually happens after the treatment in the corneal tissue? The cornea increase the stiffness, increase the resistance to enzyme, reduce the corneal permeability, and also increase the corneal rigidity, because we want the corneal tissue to be more rigid, to be more stable, to be more stiff. And that's how we increase the cross-linking, the cross-links in the, or the bond links in the corneal stroma. That will increase the stiffness and rigidity, and this is how we slow the myopia, the keratoconus progression. Is it safe? The procedure is fairly safe. And we're talking about the major concern here when we're talking about safety. The major concern is the if we're gonna cause any damage to the endothelial cells. We talked about the endothelial pump mechanism, and if you damage them, they're not gonna regenerate. So they're very important to keep the endothelial cell protected. Also, damage to the epithelial stem cells. So we know the epithelium, when you remove it, it grows back. How it grows back, there are epithelial stem cells in the limbus or the limbal area, produce those epithelial cells, and those epithelial cells migrate to cover or the wound in the corneal epithelium. So it's very important to keep those epithelial stem cells in the limbar area safe from the radiation and from the UV light. Corneal nerves also will be damaged during the surgery because we're removing the epithelium. Also, we are doing some like the riboflavin, the UVA, that can cause damage to the corneal nerves. You can see the patients after the surgery in the first few months, they have reduced corneal sensitivity, but the sensitivity improves after the surgery or go back to normal. It takes about 6 months to 1 year after the treatment. If you read in the studies about cross-linking, you see some studies that do the corneal cross-linking with refractive surgery. For example, corneal cross-linking with LASIK, corneal cross-linking with PRK. They do it mostly if the patient has, they suspect the patient have keratoconus and the patient might develop corneal ectasia after the refractive surgery. They do it with the refractive surgery. So either they do it two separate steps in one session, or one step when they do in the refractive surgery procedure. Now talking about the long-term outcome. We discussed how the change is going to happen after a few months, after 1 year, 2 years. How about 10 years? Is the patient going to progress after 10 years or not? Is it going to be stable? So this is one study that looked at over 6,000 cases of corneal ectasia. They had the corneal cross-linking done. And 95% of those cases, after 10 years, they show stability. And they measured the corneal topography, pachymetry, refraction, and visual acuity. So the topography, you can see there is no change in curvature. There's no steepening. Pachymetry, there's no thinning. Refraction, there is no significant increase in regular amount of stigmatism. And the visual acuity, because everything is stable, the visual acuity should be stable. Okay, let's move to another topic now. It's the tools that assist us in early diagnosis of keratoconus. When we first discussed the case at the beginning, it's very important to target the ones with the mild to moderate keratoconus. So in order to help ourselves to find those patients with mild to moderate keratoconus, we need to use the correct tools to help us early diagnose patients with keratoconus. So before I start, I would like someone from the audience to answer this question. Which corneal surface is first affected in the corneal ectasia? Is it the front surface, the back surface, or both surfaces, they show changes at the same time? Anyone want to? You can answer in the chat. Okay, we have one says the back surface. Back. Yeah, the correct answer is the back surface. How is this going to help us in the early diagnosis? If we know the back surface is starting early, can we use this to help us for early diagnosis of keratoconus? So let's talk about the tools. One of the greatest tools I think all of us use when we diagnose the keratoconus is the corneal imaging. We can divide corneal imaging into corneal topography. So the corneal topography, we can use something called elevation map. With the corneal topography, they provide data from the front surface, only the front surface of the cornea. So the corneal topography, you can see we have two types of corneal topography. It uses a technology, so you can see the rings here on the corneal topographer that shine lights onto the corneal surface, the front corneal surface, and the reflection of the corneal surface is actually captured with camera and then analyzed, and then give you the map. The same thing, here is the mid-mount, it has more rings, and it's the same technology. So it's very important because it detects the reflection of the pre-corneal tear film, the tear film on the cornea. So if you have a patient with the dry eye, you might have irregularity in the corneal surface with the topography, and that's because the tear film is not smooth. So you know how you need to give the patient artificial tears to help smooth the corneal surface and then take the topography. The second technology with the corneal imaging is the corneal tomography. How is that different from the corneal topography? Corneal tomography provides analysis of both anterior and posterior surface. And this is your tool because it tells you about the back surface. So we have two types. We have a pentacam and anterior segment OCT, anterior segment optical coherence tomography. The pentacam, it uses a technology, it's called the Champlain camera. It's a rotating camera, so you can see it here. This is the pentacam. This camera, it's actually rotates 360 degrees and capture images as it rotates around the eye. And it gives you an image like this. This is an image from anterior segment OCT. You can see, you can measure the curvature of the front surface of the cornea, the back surface of the cornea, and now you have both surfaces. And also if you have the front and the back, you get to measure the corneal thickness. With the other technology, the topography, this one, you only collected data from the front surface. So it does not provide you with the data with the corneal thickness. That's a very important thing to distinguish between the two. So since it's giving us the information about the back surface, now can we use it for early detection of keratoconus? So that's the question. So if anyone has a pentacam in their practice or their clinic, look for something called enhanced ectasia display. It's a specific test, was developed by Oculus on pentacam. It's very useful and it's unique. It provides you a lot of information, and it's helpful for detection or early diagnosis of corneal ectasia. It has a sensitivity of 80% and a specificity of about 80% as well. So what kind of information that we get from the cornea over pentacam? We get something called axial map, corneal thickness map, refractive or power map. There is something called elevation map, and this is what we're going to focus on. The elevation map on with the pentacam and also with the corneal topography, you can get an elevation map. Elevation map is basically, this is the eye with the keratoconus, and the yellow curve here, you call it a best fit sphere. So it's very simple. The device, we compare the cornea, the patient's cornea, to the curve. If there is any elevation, it tells you there is an elevation in this area. So this area will be, there is a depression. Here will be an elevation. So here's a normal eye. You don't see any elevation or depression because it's normal. So this specific test, it does two types of analysis. This first one with the best fit sphere, and they have another curve that fits the keratoconus eyes better. So if you can see, if you fit the keratoconus eyes better, you can see the cone shape more elevated and you can detect it better. So let's see an example about this with the Pentacam enhanced ectasia display. Here's a patient with the corneal ectasia, let's say keratoconus. This is the report that we get from the Pentacam. So I want you to kind of pay attention with me to let you know what's the components of this report. So here we have 3 maps on the left. Those 3 maps, all elevation. This is the entire report is for the left eye. You can see everything is for the left eye. These 3 on the left, right here, are for the front surface. These 3 are for the back surface. The first one, what we do is the analysis of the best fit sphere, the one we just talked about here. They do it for the front and back. The another analysis they do, it's the new reference shape. So the new reference shape, this one, this will be these 2 maps. This is for the front, this is for the back. And now the last map is the difference. So they take the difference between this map and this map and they give you this difference map. And the same thing for the back. So the question here, you can see the elevation first with the best fit sphere. It shows you there is an elevation. First, you can see the back is elevated more than the front. And that's confirm that the back surface has more changes and starts first than the front surface. With the new reference curve, you can see the elevation more because we just talked about it. The elevation will be more in this, and you can see it with the map. The elevation will be more, but it's more in the back surface because it starts early than the front surface. This is your map. If you see there is a red area in the difference map in the front or the back, then you can say, okay, there is something wrong. And also there is all these parameters. You can see if they are in red or yellow, you can see if there is a borderline, if there is an indication red flag, you need to monitor the patient. So if I have a patient, this patient will have about moderate keratoconus. It's very obvious. So let's see if the patient has a very mild and even doesn't know that have the keratoconus because it doesn't affect their vision. So this is the second example. So the term or the name preclinical corneal ectasia. When we say preclinical, that means it still cannot be easily diagnosed. The patient doesn't have any symptoms. Vision is still be correctable to 20/20. There's nothing wrong with the patient, but they still have keratoconus. It's still a very, very mild stage. How is the enhanced ectasia display going to help us? The same map, the same thing, the front. You can see the front is with the both analysis, best fit sphere and the new reference. They're both in the green zone. There's no difference. And here, the difference map showing everything is normal. When you look at the back surface, and here's where you find best fit sphere, there is a slight elevation. When you see the other analysis, which is this one, now you see there is an elevation and kind of significant. And it tells you in microns, there's like a 32 microns elevation, 36 microns elevation. And with this one, it's a 20 micron elevation. And when you see the reference map, now you see this area is likely to have in the back surface to have a progression or the starting of changes that indicates a corneal ectasia. So this is one of the tools. If you have this in your practice, use it. And it's very useful, it's very easy. And if you have this patient, I would follow up with this patient. I would tell them, come back after 2-3 months, and I will do the same test again. Monitor their vision, their refraction, if there's any changes that might happen. So just keep that in mind. So this is one of the best tools. And also you can see there is a red flags in some of the parameters. You just don't refer this patient right away, just monitor them. Give them a follow-up appointment after 3 months and then see how, if there is a progression, vision they start to get affected, then refer them to cornea specialists. Other tests or tools, you can monitor the corneal thickness change or a central corneal thickness, corneal hysteresis, if you have a device to measure that. Some studies indicate that monitor these variables or these measurements can help you in an early diagnosis for keratoconus. This is the last tool is it's when we measure wavefront analysis. Some pentacams have a wavefront analysis. They give you what we call higher order operation. So the human eye, like any optical system, has higher order operation. Higher order operation, we have many, many types of higher order operation, and the mathematics behind the higher order operation is very complicated. But we have something called spherical operation, vertical comma, radial astigmatism, and all that. But the normal eye, healthy, normal eye, there's nothing wrong with the refractive surfaces of the eye, does not have, usually have a specific amount of higher order operation. But if the patient has any irregularity in the corneal surface, anything wrong with the refractive surfaces inside the eye, they have abnormal amount of higher order operation. So we're talking about this type of higher order operation, is the vertical comma. So this is an optical system, it's a lens. The vertical comma is usually when you have a parallel light, they're parallel rays off axis, they're not on the axis. And when they focus, they focus in a shape that not in one point, they have a conic shape. So here's an example with the comma with seen through an optical system, a telescope, and then it's corrected optically. With the keratoconus, if the patient has keratoconus, you can see if the keratoconus is still mild, they have an elevated or higher amount of vertical comma. With the keratoconus getting worse, the amount of comma operation will be higher. And that's why, because why is the vertical comma? Why is the horizontal comma is affected? The vertical comma, because you can see usually the steepening happens in the corneal surface. It's in the inferior part, and the superior part will be more flat. So that's why the rays will be focused differently in different plane or in different spot from the superior than the inferior part of the cornea on the retina. So this is one of the tools. If you see, there is several tests. Vertical comma is elevated. You see higher amount of vertical comma. You see the patient with the enhanced dictation display, some changes in the back surface of the cornea. Now you can say this patients need to be monitored, and then when you have evidence of keratoconus progression, refer them to cornea specialists. Reaching to the end of this lecture, I just wanted to answer some questions that I think most of you will have these, and are very important to discuss. The first question is, at what point should a patient be referred for corneal cross-linking? Suitable patients, we talked about this. Adequate corneal thickness, we talked about the rule of 400 microns. K reading, or the steep K has to be less than 58 diopter. No central scarring, that's what we aim for. Age is typically less than 40. And you need to have documented evidence of progression. You either monitor the patient and you see, okay, there is corneal thinning or there is corneal steepening, or you have the patient have their data or report from another ophthalmologist or optometrist. Second question, can a patient return to wearing contact lenses or soft contact lenses after cross-linking? Usually after 3 months of after the 3-month follow-up, we check the epithelium. If it's well closed, healed, no irregularities, the patient can return to wearing contact lenses. Let's say if the patient is, everything is normal after 1-2 months, just tell your patient, do not wear the contact lens excessively after the surgery in the first 6 months. The reason why, because we have a reduced corneal sensitivity, they can wear them for a few hours a day, but not the entire day until the corneal sensitivity improved back to normal. After 6 months, if everything is normal, nothing to worry about, the patient do not have any problem with start wearing contact lenses. The last question here, how long is the treatment is expected to last, and will retreatments be needed? So usually the effect of cross-linking lasts more than 10 years, should last more than 10 years. But in some situations, for patients like the study we talked about, the pregnancy, patients with neurodermatitis, patients who are suffering from stress or hormonal changes in their body, applications of prostaglandins, specific medications, those can change the duration and may have a new progression of keratoconus after the surgery. Will the retreatment be needed? Does the patient, if we have the corneal cross-linking, will they need another corneal cross-linking after in the future? It's very unlikely for some patients, about 2.5% of patients needed another surgery. This is the main question. What is our role as optometrists? Our role, I know we do not do the surgery, and we all know that we don't do the corneal cross-linking, but our role is extremely important, is extremely significant and necessary. What can we do? We can do more than you think. First, early diagnosis patients with keratoconus. Because when you have a patient with keratoconus, they come to your clinic, they don't go to see an ophthalmologist. It's more likely to come see an optometrist because they know there is something wrong with their glasses. So it's your job, you are at the front line to diagnose this patient correctly with keratoconus and put them in the right direction if they needed corneal cross-linking. Identify patients who are the best candidate for the corneal cross-linking. We talked about the criteria, we talked about the surgery, and now I think you all know who are the best candidates. Refer patients to corneal specialists, and with the right communication, you can tell your ophthalmologist or the ophthalmologist or corneal specialist, this patient has shown a progression and he's diagnosed with keratoconus a few months ago, and now he's progressing, and I think he is the best candidate for the procedure. Provide the appropriate patient education about the condition and the corneal cross-linking. The condition we're talking about, keratoconus. It's very important the patient knows the keratoconus, it's not just their vision is reduced, they're going to be corrected. It's progressing in most cases. It's going to get worse with time. And also tell them about keratoconus. We're going to talk about what they need to know about it. And this is the part. What should I tell my patient, and what should the patient know about this procedure? This is the most important point. This is a not refractive surgery. This is not a refractive surgery. And the reason we need to make this clear, because they think they might have something similar to a LASIK or a PRK. This is not the case. And state clearly, or tell them clearly, the purpose of this surgery is to stop a progression that is most likely to happen in the future. But the improvement in vision, it's going to be slightly. So you will be needing glasses or contact lenses. Some patients might be afraid of doing or deciding to do the surgery, so they decide to take their time. They say, okay, I will think about it next year. Also tell your patients, if the disease is progressing and we have evidence that the keratoconus is still progressing with patients, tell them that the earlier treatment, the better the outcome. In cases, if they need to take another expert opinion, to see another doctor, that's fine. But tell them the time matters. Like they should not take a longer time than it should, because the disease will be progressing and they might not be beneficial. The surgery might not be beneficial for them after that. It may take several months to see better after the surgery or the procedure. This is also important to say to the patient. With the complications, with the corneal haze, the changes that happens in the few months after the surgery, you need to tell your patient very clearly that it's gonna take time for vision to come back. Will need to be refitted with contact lenses or glasses after the procedure. And the reason why, because most of them will have refractive error. And that refractive error is not going to be corrected by the surgery. And after the surgery, they're going to need to wear corrective lenses, either contact lenses or glasses. So tell your patient that. And it's not a cure. There is a chance of patients, or there is a percentage of patients still have a progression as we talk after the surgery. So it's not going to stop 100% your keratoconus progression. Tell them how it's performed, how it's done, what are the steps. It's going to take 1 hour or longer. Your eye is going to be open the entire time. You're going to put drops in your eye every 2 minutes, and the entire procedure, and the shine UV light, and that's how it's done. So the patients need to be informed of about these points. So if you want to take anything from this lecture, just take the information from this slide. I will be happy. The corneal cross-linking is an effective and a safe procedure. If we talk in the epi-off, it's about 93 to 95% effective or successful. The early and precise diagnosis of keratoconus is an important key to ensure better outcome with the surgery. Our role of optometrist is essential in early diagnosis, monitoring the disease progression, referring to the corneal specialist, providing adequate patient education, providing the needed optical correction. And I think we can do more than that. And these are some references that you can refer or go back to if you want to read more about this topic. And thank you very much for listening. And I hope this was very helpful to you. If you have any question, you can either ask now in the chat or raise your hand. We open the mic. You can email me. You can follow me on Twitter and text me. Yeah, you can ask any question if you want. Thank you very much.
Thank you, Dr. Mut'ab. Wow, you did very great job, actually. Well done. You cover all the main point, actually. I prepare many questions, so you answer all the question, actually. Let's start with if the audience they have some questions. But before that, حابة أنوه إنه يا ليت الجميع يتأكد من تسجيله لمن لديه عضوية في جمعية البصريات. التسجيل على هذا الرابط تم إرساله الآن عن طريق الشات. وننتقل الآن إن شاء الله لفقرة الإجابة على الأسئلة في حال وجود أي استفسار. عندنا تقريبا كم شخص I think they're raising their hand since the beginning of the lectures. أستاذ إبراهيم، في حال عندك أي استفسار نفتح لك المايك بإذن الله. وفي عندنا برضو مستر خبراني. I'm not sure if I said correctly. Okay. Okay.
We can start with the questions in the chat.
Let's say, yeah.
Abdulillah asking about how can we control the complications of the epi-off. To answer this question, the things we talked about with giving, I think if I go back to that slide, it's the correct follow-up. We need to see the patient. We need to see the patient the day after, and then after a few days, make sure the epithelium is growing back normally, and there is no delay in the wound healing. Giving the patients the right medication, the antibiotics, also the steroids. It's very important to control any complications may happen. So the right follow-up and also the medication and patient education, also picking or choosing the patients who are the best fit for the procedure. all this can reduce the percentage of the complications that have happened with the. So we do our best in terms of reducing the complications. So this is how we do it. But we want to keep with the epi-off. We want to keep the efficacy high. That's what we aim for epi-off. I think one of the questions is asking about the corneal hysteresis. To go back to that slide. So the corneal hysteresis, it's one of the measurements. It has its definition here. So an assessment of the corneal ability to absorb and dissipate energy tissue. So it's usually when you kind of apply energy to the cornea and see how the kind of cornea bounces back and forth. And you measure that. There are devices to measure the amount of energy that the cornea absorb and then put back. So with the corneal, with the weak corneal tissue in keratoconus, usually there is the amount of energy will be different than normal. So this is one of the, it's actually the corneal hysteresis is used more to diagnose glaucoma cases with elevated IOP. But also it's been studies showing it with the weaker corneal tissue in keratoconus. It's actually the corneal hysteresis can show you the different results.
Okay, thank you.
Any more questions?
I think this is from أستاذ أحمد. تفضل المايك معك.
السلام عليكم. شكرا على إتاحة الفرصة. When we diagnose the early keratoconus and if we see the patient with normal pentacam and with normal baleen imbriation, but there is abnormal in the curves biomechanical cornea, so we can say this patient need to early cross-linking or not.
Let me see if I understand your question correctly. You're talking about just one test that you did and it's showing abnormal results. Is that enough to make a diagnosis?
Yes, of course.
So the diagnosis of, we know the diagnosis of keratoconus, it's very similar to the diagnosis of glaucoma. You cannot say the patient who has elevated IOP has glaucoma right away. So with keratoconus, it's similar. So what do we do? For example, let's say if the patient, one second. If the patient, let's say, has a reduced thickness, or that's one thing. Another patient show this. I cannot say this patient has keratoconus right away, but what I can do is monitor the patient. I do not refer them because one of the things that you need to do before you refer them for corneal cross-linking, you need to make sure first you diagnose them with keratoconus. Second, you need to have an evidence of progression. So if I see this patient right here today, and it's showing some elevation with the pentacam, I ask the patient to come back after 2-3 months and then do this again. If I see there is a progression, there's more elevation happens in the back surface and maybe here too in the front surface, now I have an evidence and now I can refer them. But I need to have an evidence to diagnose and to show the progression. I hope this answers your question.
Yes, thank you.
You're welcome.
ننتقل الآن معنا الدكتور وليد. Let's welcome you, Dr. Walid. The mic is with you.
السلام عليكم ورحمة الله وبركاته. يعطيك العافية دكتور. Very well done and very informative lecture. We all, I think, enjoy it. My question is, some of the corneal surgeons perform cross-linking for patients without keratoconus if they have thin cornea. So they to enable them to do LASIK surgery. I'm not sure if this is actually a very safe way to do it. Is there any insight about this process? Thank you.
Thank you, Dr. Walid. So your question is about they do the refractive surgery, PRK.
Refractive surgery for normal people without keratoconus, but if they have thin cornea, so that, you know, they have to have some leftover after the they have to do some calculation, so they have enough corneal thickness after the LASIK. So some of them, they do cross-linking, so they increase the thickness of the cornea and then they perform the LASIK surgery.
I don't know about, like, for the cross-linking, we actually increase the cornea. So they might have a reason why they perform the cross-linking. Maybe because patients with thinner cornea might have a chance or to develop keratoconus in the future.
So can be done for normal patient, or something only should be for abnormal corneas or the corneas with ectasia?
I think the surgeon has, if they have a concern about maybe if they've developed keratoconus in the future, maybe they will do it, because it's at the end. This surgery is approved by the US FDA, the one I just presented. So the surgeon.
But is it approved for all? I think you showed that it's not approved for all conditions, but
yes, just
it's efficient. Yeah, just keratoconus approved. So it's not approved for just thin cornea.
No,
this is yeah.
Just a thin cornea is not enough reason to do the surgery.
All right.
But
thank you so
the
much.
thing is, you're welcome, Dr. Walid, and thank you for the great question. So this one here, I'm just looking for the correct slide. So the reason, maybe this is maybe the same or a little bit different than when you asked. So here they suspect the patient, they might have a thinner cornea, but they need to do refractive surgery. So when they do the refractive surgery, along with the refractive surgery, they have for a prophylactic reason or treatment, just to prevent something might happen in the future. They do the cornea cross-linking. But using the cornea cross-linking to increase the thickness to do the refractive surgery, I don't know about that. And I don't know if it's just to increase the thickness. I don't think it's enough reason. The surgeon has to have a valid reason to perform the cornea.
Yes, I think maybe there is also ethical issue here.
Right, I agree with you.
Yeah.
Thank you, Dr. Walid.
Okay.
I think we have Saif.
Yeah. أستاذ سيف المايك معك.
Thank you, Dr. Mudhib, for your nice and informative presentations. During your lecture, you said, I think nursing is not recommended for cross-linking. What is the reason behind this? And also during the lectures, you mentioned a lot of complications happened after cross-linking. As eye care providers, we know the benefit of this procedure, but how to increase the awareness of the patient to accept this post-surgical complications? Thank you.
Yeah, thank you for your question. How to convince the patient? It's very important to tell the patient everything. They can make an informed decision. That's the first thing. Also educating them about their progression. The first case we mentioned, how the patient is going to move, the disease progress from spectacles to GP lenses, and then some of them end up doing a corneal transplant. And the outcome for corneal transplant, they're not that great. So there's a lot of fluctuation in the results. So what we can say, this to save your vision from anything can happen in the future with the progression of the disease. So we have evidence that your disease is progressing, and we just tell them everything. The surgery is safe, the surgery is successful, but also they need to know about the complications and how are we going to control those complications. But it's not going to be 100% safe. So I think having an honest conversation with your patient, telling them everything, and having their interest first, to save their vision, I think that will convince them enough. And I didn't hear your first question. You asked about something, and I wasn't. The voice was not clear.
Yes, you mentioned nursing or something like that is not recommended for these procedures. What's the reason behind nursing? Yes.
The only thing they mentioned, it's during nursing and during pregnancy, the women go through hormonal changes. And those hormonal changes, it's like it's similar to anyone with kind of a significant level of stress. Hormonal changes in the body, that's the only explanation they provided. I did not look into the details of that.
Thank you.
You're welcome.
Thank you, Dr. Matab. Let's say if we have some other questions.
I think there is a question from the audience. Thanks. We hope that we can I always discover the keratoconus by the retinoscopy, even if there is no astigmatism, there is a scissor reflex. That's correct. And make sure that by the topography. My question is related to our lecture, but not exactly. Nowadays, we have in pharmacy lubricants drops that have riboflavin. In your opinion, it's used normal patients. I'm not familiar with those, but it depends if it's going to be a significant amount of riboflavin, and what's the benefit of having a riboflavin in artificial tears, and also if they're using it as a lubricant. You still have the epithelium on, and it's going to prevent most of it to enter the corneal stroma. But I don't know about the actual benefit, why they add the riboflavin with the artificial tears. But yeah, you're correct about the scissor reflex with the retinoscopy. This is one of the known signs of keratoconus, and you have to confirm that with topography. But I was focusing today about more about the early diagnosis. You might not see the scissor reflex in patients who with a preclinical, because it's preclinically you cannot detect or diagnose this patient with the normal clinical techniques like the retinoscopy that you mentioned. Nasser asked, is it right that 10% of patients could have their best corrected visual acuity improved one line after the cross-linking? So we said about the vast majority of patients, they either have the same vision after the surgery, best corrected visual acuity, or slightly improved. I do not know about, so since it's said there is a cornea flattening happens, I would expect a slightly improvement in best corrected visual acuity. But the exact percentage, I'm not sure. But going back to the main purpose of the surgery, it's good to have an improved visual, best corrected visual acuity by one line, but it's not our main goal. Our main goal is to stop the progression. If we get an improvement of best corrected visual acuity, that's great. So even if I had a patient and after surgery, their best corrected visual acuity is this exactly the same, I'm happy as long as they do not progress worse with time.
Thank you, Dr. Matab. I think we have other question from Nafisa. I'm not sure if I say it correctly. I think the mic is with you now.
My question, we need to refer to cross-linking after monitoring and see progression, or there are some cases we can immediately refer to cross-linking.
Yes, correct. You have to have a right diagnosis and an evidence of progression. Let's say you're asking if the patient has a moderate, so it's a very obvious they have a corneal or keratoconus. Should I refer them? Some patients, they might have keratoconus or steepening in the inferior part of the cornea and thinning, but it's stable, and it's a very low amount of patients. So I would tell you just to monitor the patient, unless the patient has results from another clinic. So let's say they have a result from 6 months ago. They done the test in another clinic, and you see the results from today in your clinic from the result from 6 months ago. You see that how they progressed fast, and now you can say, okay, they're progressing, and now I have to refer them. But you cannot just refer right away, and you can if you know the corneal specialist, just to explain to them they have moderate keratoconus, they can be eligible, and the corneal specialist might may monitor the patient, follow up with the patient, or ask you to follow up with the patient to see the progression.
Okay. Also, we have other question from Ustad Nasser. Go ahead.
السلام عليكم ورحمة الله، يسعد مساكم جميعا، تقبل الله الطاعات. يعطيك العافية دكتور متعب على المحاضرة الدقيقة. I just need to stress in something, Dr. Metaib, that cross-linking, the only procedure actually now being approved to halt the progression of keratoconus, is nothing to do with ICRs, you know, because when we refer, you know, patients to some surgeons, refractive surgeons, okay, they propose for the patient to stabilize the cornea, actually inserting the intracorneal rings, plus doing, you know, the cross-linking, which they propose to stabilize the cornea. In fact, we know that ICR is like a refractive kind of correction for some keratoconus cases. So it's nothing to do, you know, to combine the two it's not must, you know, to combine the two surgeries together, you know, to help the progression. And in the same time, some patient who already had, you know, the cross-linking, which actually, you know, almost stabilize, you know, the cornea by, you know, strengthening the bones, as you have explained, Dr. Metaib. And then later on, we got some refractive surgeons who proposed also to do the ICR. We know the ICR should do, you know, the opposite. It should change, you know, the corneal flattening, you know, the corneal stromal layer to get better visual acuity. So how these two procedures, you know, should be done, you know, together. Let me say you want to do the ICR, so you should do the ICR first, and then when you stabilize the cornea, you should do the cross-linking. And some of the surgeons, they combine it on the same setting. But I don't see a point where some doctors, you know, they do the cross-linking, and maybe after 2 visits, then they propose, you know, the ICR for the patient to improve their visual acuity. I just want a comment from you, Dr. Mutaib, on this. Thank you.
Yeah, thank you, Dr. Nasser, for this question. I think it depends on the patient. I don't have a lot of experience, but I can answer from your question. If so, you're talking about the corneal rings, correct?
Yes, the corneal.
And after, it depends on the patient. Having the corneal rings after the cross-linking, just to stabilize, because the cross-linking, the idea of it is to stop the progression. If you have this goal achieved, that's great. I don't think it's needed to do the corneal rings to improve vision, because now you stop the disease. That's what you want. But you need to improve the vision. You have contact lenses, a lot of types of contact lenses you can choose from, and you have spectacles. If the patients do not improve with the spectacles, you can go with the specialty contact lenses. You have a lot of types, like the GP lenses, the soft lenses, the scleral lenses. It depends on the case. I don't think it's because you are doing more pressure on the cornea. I think the corneal surgeons are know better than me in this field, but I think having refractive or having a surgery after cross-linking just to improve vision, I would not go with that, especially if the patient's vision can be achieved and corrected to 20/20 with the spectacles or contact lenses. If not, maybe I would go with that, but it has to be a valid reason for me.
Thank you, Dr. Metaib. What it makes sense, you know, that ICLs, maybe it can be done, you know, after the cross-linking if the case is suitable. But if you want to stretch the cornea again to make it more flatter, you know, with the, let we say, the rings after doing cross-linking where it's stable. Myself, I don't see a point, you know, behind this, but I think there's some surgeons will still doing this. So in my opinion, either to do, you know, you combine this the procedure together, you do the ICR on the same sitting, you do the cross-linking, or otherwise you do first, you know, the ICR, let the patient 6 months or 1 year follow up, improve the vision, and then you stabilize the cornea on that, you know, flattening. Thank you so much.
No, you're welcome. Thanks a lot. I think we do have a question here. Yeah, someone asked about the lubricant with the riboflavin. I don't know any information about that. And what's the main purpose of having riboflavin in lubricants or artificial tears? And what's the amount of riboflavin? I have no idea, and I'm just hearing this from you. I'm not familiar with that. So sorry, I can't provide you a right answer about about your question. The last question I want to ask about to make the LASIK to correct the refractive error after the. I've read about doing the refractive surgery, either the LASIK or PRK, after the corneal cross-linking, and some studies have suggested that if everything is stable, the corneal thickness is good, you can go for refractive surgery. I think they would go more with the PRK, because the PRK does not take a lot of the corneal thickness as in the LASIK, because in LASIK you have the flap and then you take part of the corneal stroma. So it depends on the case. And if you need the material for this, you can email me and I can send you the material if you think it's helpful in your clinic to read more about it and as a reference. And thank you very much.
Thank you, Dr. Mattab. وصلنا لنهاية هذه الأمسية وجدا شاكرين وممتنين لك دكتور متعب بصراحة. you cover all the points. It was great presentation. نطلع إن شاء الله لاجتماعات أخرى قادمة بإذن الله. نشكر الجميع ونشكر أيضا الجمعية السعودية للبصريات ونشكر أيضا الجمعية الشرق المتوسط للبصريات أيضا. ونستودعكم الله ونراكم على خير وفي أمان الله.